ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರಗಳು. This is Dr. Manjunath Awadkhan. Welcome to my YouTube channel again. Let's learn medicine together and in a very simplest possible way. Today I am doing high-yield MCQs on refeeding syndrome. After this video, you will be able to answer all the questions, be it MCQ, be it theory, be it Viva, and your strike rate will be 100% in neet PG as well as neet SS. So let's solve some MCQs. Which electrolyte imbalance is not classical of refeeding syndrome? And the options are hypophosphatemia, hypomagnesemia, hypocalcemia, hypokalemia. Answer for this question is hypocalcemia. Hypophosphatemia, hypomagnesemia, hypokalemia are very classical of refeeding syndrome. We can see hypocalcemia, but it is not a classical. And the pathophysiology for hypocalcemia also we are going to see. So next question, in refeeding syndrome, which vitamin deficiency can cause lactic acidosis and death? And the options are vitamin A, vitamin C, vitamin B1 and pyridoxine. For solving this question, we need to know the concept. By guessing, you may get right sometime, but the chances of getting right are only 25% when you are guessing. 75% chances are there ki you may get wrong. So for solving this, you need to know the concept, why it causes lactic acidosis and which vitamin is involved in this pathophysiology. And the answer for this is option C, vitamin B1, thiamine. Okay. A severe acute malnutrition child developed refeeding syndrome. Potassium levels are not improving even after potassium supplements or correction. What will be your next step in management of this kid? Check serum phosphate level, check serum sodium level, check serum protein level, check serum magnesium level. If you don't know concept here, there are chances you may be wrong. There are high chances you will get wrong in this question. Okay, and the answer for this is, next step will be check magnesium level. This will be the most appropriate answer here. Okay, small concept from severe acute malnutrition. Due to less energy in severe acute malnutrition, there is decreased activity of this sodium potassium ATPase due to decreased ATP. So the function of sodium potassium ATPase is to pump sodium outside and potassium inside. So 3 sodium will come outside and 2 potassium will go inside, but this is not functioning. So sodium starts accumulating inside the cell and extracellular sodium appears low apparently, and potassium cannot enter cell, so there will be urinary loss, and which causes hypokalemia, and it is true hypokalemia. However, hyponatremia is due to redistribution or dilutional hyponatremia, and management correct hypokalemia but treat hyponatremia only if symptomatic. If you treat hyponatremia without any symptoms, child may worsen and child may die. Okay, so be careful while treating hyponatremia in severe acute malnutrition or malnourished child. And once you start feeding, this ATPase start working and there is a shift of electrolytes. Refeeding syndrome is a life-threatening condition that may develop in malnourished individual when nutrition introduced too rapidly. It is marked by significant electrolyte disturbances, most notably hypophosphatemia, hypokalemia, hypomagnesemia, and thiamine deficiency. You have to remember all this electrolyte imbalance as well as thiamine deficiency. Most important line from this video. Preventing refeeding syndrome require cautious, gradual increase in calorie intake along with close monitoring of the electrolyte as well as to achieve optimum level. Rapid electrolyte and fluid shift in response to surge of insulin brought by presence of nutrient can lead to numerous medical complications. This summarizes the refeeding syndrome. when we start rapid feed in malnourished or starved child, there is release of insulin and which causes shift of electrolytes across the membrane of the cell. So this energy intake increases and sodium pump activity starts. So sodium comes out of the cell, and along with that it drags water, because water follows the sodium. Wherever sodium is going, water follows it. And rapid release of the sodium from cells, expansion of extracellular and plasma volume, and increase uptake of, that is pump up glucose, potassium, magnesium, phosphate into the cell. So this image shows potassium, phosphate, magnesium, glucose are going into the cell. And here we have hypophosphatemia, hypokalemia and hypomagnesemia from the serum, as well as decreased thiamine. So whenever there is a malnourished child, low energy stores and all the pumps are not working, even sodium, potassium, ATPase is not working. So once we start aggressive feeding, there is a release of insulin, and which causes shift of fluid and electrolyte as well as nutrient across the cell, which leads to refeeding syndrome. Sodium comes out of the cell and water follows it. Phosphate, potassium, magnesium are pumped inside the cell, as well as glucose goes inside, and thiamine is utilized for the metabolism of carbohydrate, and thiamine deficiency occurs. Okay, and which leads to lactic acidosis. Whenever someone does fasting, initial few hours glucose act as energy source, available glucose. Later there is a glycolysis. Still he is fasting, then there is a gluconeogenesis. Then at the end there is ketone, which act as energy source. Okay, so this is the image showing starvation. When there is a starvation, insulin is decreased, glucagon and catecholamines are increased, and there is gluconeogenesis as well as catabolism. It's a state of catabolism, breakdown. Okay, and there are other nutrients also depleted, like electrolytes, vitamin, thiamine, vitamin B12, all are deficient in malnourished children. Okay, so when you start refeeding aggressive, there is an increase in insulin and it is a state of anabolism. There is uptake of glucose, potassium, magnesium, and utilization of thiamine in the metabolism of carbohydrate, as well as there is a already thiamine is deficient. Okay, and which leads to hypophosphatemia, hypokalemia, hypomagnesemia, thiamine deficiency, salt and water retention. These all are the characteristic of refeeding syndrome. Okay, then whenever child is fed, there is a glucose inside the cell, and which goes into glycolysis and then pyruvate, but this pyruvate will not be converted to acetyl CoA. So when there is a refeeding syndrome, the child will suffer from thiamine deficiency. Why there is a thiamine deficiency? One is the stores are less. Okay, other is utilization of available thiamine for this pathway. So finally there is a deficient thiamine, which leads to malfunctioning of this pyruvate dehydrogenase. So it will not converted to acetyl CoA, and which will send it to lactate by lactate dehydrogenase and formation of lactic acidosis. This is the reason and the concept for lactic acidosis in refeeding syndrome. Okay, and acetyl CoA will not enter into TCA or Krebs cycle. This is the table from Nelson. What you need to remember is this is very important. The headlines. There is hypophosphatemia, hypokalemia, hypomagnesemia, thiamine deficiency, sodium retention, water retention, and hyperglycemia. This is the new thing. There is hyperglycemia also in the refeeding syndrome. Okay, and this one you need to remember. This one, the magnesium can lead to refractory hypokalemia and hypophosphatemia because hypokalemia and hypocalcemia, because renal loss will be increased. Even if you treat hypokalemia, potassium is not going to correct because of hypomagnesemia. Okay, and this is hypocalcemia also because of hypomagnesemia. And if you want to see hematological, there is hemolysis thrombocytopenia. Okay, and in hyperglycemia, due to hyperglycemia, there can be ketoacidosis also. There are two acidosis you need to remember. One is because of lactate deficiency, because of thiamine deficiency you can have a lactic acidosis, and because of hyperglycemia you can have a ketoacidosis. Okay, because of all this electrolyte imbalance, they can develop arrhythmia, they can develop CCF, and hypomagnesemia can cause tetany because of the hypocalcemia. Okay, there's another question. Which among the following has highest risk of refeeding syndrome in severely malnourished children? Oral feeding, enteral feeding, parenteral feeding, all have same risk as it depends on the amount of calories. Answer here. I know it is a tricky question, and if you have not read, definitely you would mark option D. That looks much easier for you to mark, but the right answer is option C. Parenteral feeding has a highest risk of refeeding syndrome, and this line is taken from the Nelson. So what does Nelson says about this? Refeeding syndrome occurs as a result of oral, enteral, or parenteral, and it has a highest risk of developing refeeding syndrome. And the MCQ questions are taken from the Nelson lines, especially which are written in bold letters or marked or in between the lines. Okay, this is the fifth question. All of the following statements about refeeding syndrome are true except it is exclusively seen in pediatric age group. Hyperglycemia may occur during refeeding syndrome. Nice guidelines are used to identify patient at risk of refeeding syndrome. Hypomagnesemia may cause refractory hypocalcemia. And we know that hypomagnesemia may cause refractory hypocalcemia. Okay, so this is the right option. Nice guidelines are used to identify patient at risk of refeeding syndrome, and we don't know this. Let's go to next option. Hyperglycemia may occur during refeeding syndrome. We have read and we know that it is true option. Okay, and it is exclusively seen in the pediatric age group, and this is the wrong option here. It is not exclusive for pediatric age group. It can be seen in adult as well as elder patient, geriatric patient, and any animal who has starved and started on rapid feed. And the last option remaining is nice guidelines are used to identify patient at risk of refeeding syndrome. There is a table in Nelson which mentions this risk stratification according to nice guidelines. You have to go through that because previously question has not been asked on this, but may be asked in future exams. Okay, thank you.